Hi, everybody. Welcome to the second week of Lent. It's so pleased to be able to talk to everybody. Today we're going to talk about signs and symptoms of neurodevelopmental disorders, actually aside from ASD. And here are our speakers tonight. We're going to focus on physical disabilities in my presentation. Dr. Barbara Felt's going to talk about genetics and neurodevelopmental disabilities. And Ann, as we just heard, is going to talk about fetal alcohol spectrum disorders. And I want to remind all the trainees that in terms of ASD, there is a wonderful YouTube presentation. I've watched most of it at this point, which will bring you through the whole diagnosis and some of the treatment options for ASD. And everybody should take a look at that as part of their homework. But let's start tonight to talk about physical disability. Here's our learning objectives. We want to understand the characteristics of 4 types of pediatric onset physical disabilities. We want to discuss the implications of these disabilities on growth, development, and function. We want to describe some of the medical therapies based on medical and therapy-based interventions for these syndromes. I say that specifically because there are many other types of interventions, such as psychosocial interventions and community interventions. That's not my topic tonight. We're going to talk about some medical and therapy-based interventions. So first I want to remind everybody that children are not just small adults. This is why. They grow, they develop, they play. Children are dependent. We don't work on making children independent where they are. We know they're going to be dependent until they grow up. They go to school and they grow up, and they grow up with the disability. And that's all is what we want to talk about tonight in terms of how the various syndromes that children have can influence all of these
areas of growth.
So for example, growth. Let's talk about growth for a minute. Growth is dependent on many things. It's dependent on a person's genetics. It's dependent on their nutrition, what nutrition they have available to them, and what nutrition their body is able to take in. It's dependent on their overall health. If a child has chronic illnesses, that will take a lot of their calories and won't have it available for growth. And there's many connecting parts that lead to growth and influence growth. For example, parts of the body that don't have blood flow won't have as good growth. If a part of the body does not have proper nerve input, it won't have appropriate growth. And then the hormonal environment, such as growth hormone. Everything must work together for proper growth. In a sense, we look at growth as health. We all know the pediatricians measure growth and then comment on growth to get some idea of how healthy the child is. But in some sense, growth is the enemy, particularly in one of the conditions we'll talk about, cerebral palsy, where the muscles don't grow properly. The bones will grow more properly and will lead to contractures and different kinds of problems. So sometimes growth can be a problem. Let's talk a minute about development. This graph I particularly like. It gives a visual presentation about how we think about development. The red line is normal development. As time goes by through our first 2 years of life, we grow, we develop, we gain developmental skills, and then we get to a certain point in our lives where development is fixed, we improve skills, and then of course the red line should at some point start dropping off, but I didn't want to think about that, so we didn't put that into the slide. The blue line is a child born with a disability. They will also grow, they will also develop, and depending on how involved they are with the disability will give us the curve of that line. If their disability is mild, it'll be closer to the red line. If it's more significant, it'll be much closer to being a flat line. And then the green line is an acquired disability. This is a child that is developing normally and then has trauma, an accident, something like that occurs, and their development falls off. They lose skills, and then through the process of rehabilitation, we bring them back up toward normal development as much as possible. This is a table of some of the more common developmental skills that children get. There's these 4 main categories that I like to think about: gross motor, fine motor, language, and social skills. And then we think about it by their age. What are the skills that we expect a child might have obtained by a certain age? Now this chart is a cheat sheet. It's certainly nothing fixed. You need to learn your developmental milestones much more than in this chart, but this will give you some idea of some of the things that we look for when we're in clinic as sort of a child is moving along in their development. So with all that now, let's talk about some of the specific syndromes. First of all, cerebral palsy. This is the current definition that we use for cerebral palsy, developed by a group of prominent researchers in 2005. Cerebral palsy is a group of disorders that develop of the development of movement and posture, causing activity limitation that are attributed to non-progressive disturbances in the fetal or infant brain. The motor disorders of cerebral palsy are often accompanied by disturbances in sensation, cognition, communication, perception, and/or behavior, and sometimes by a seizure disorder. I want to point out that the words that are highlighted here are the words that are most critical in the definition. We always talked about a concept of 4 parts that defines cerebral palsy. First off, it's something that happens to the brain. Secondly, it's something that happens to the brain and causes problems with movement and posture. It's non-progressive in the fact that the brain does not steadily take time. It's something that happens right at the beginning of life, in the fetal or infant period. When we think about cerebral palsy, there are many syndromes that children can get that give a picture that's very similar to cerebral palsy. Children have stroke, children have brain tumors, near drowning episodes, or encephalitis. All can have pictures that look like cerebral palsy, and many of the things I'm going to say right now will have a similar, will apply similarly to those children. So what are the risk factors for cerebral palsy? Well, in the prenatal period, there's inflammation inside the uterine environment. The uterine environment is very important for how we think about most cases of cerebral palsy. Sometimes inflammation can be caused by intrauterine infections, which can trigger the inflammatory environment and then even trigger premature labor. Hypothyroidism in the mother is a risk factor, and then there can be malformations and other genetic factors which can lead to a child born with a presentation that we would describe as cerebral palsy based on the definition that we just saw. In the perinatal period, there can be asphyxia, loss of oxygen during the time of birth, and as we mentioned, premature birth, which will often be accompanied by a child having bleeding in the brain in the first few days of life, which leads to the presentation of cerebral palsy. Postnatally, there can be asphyxia, for example, a child who may have a near drowning episode, or a child who may accidentally have an accidental strangulation, stroke as we mentioned, or brain injury. All of these things can be classified as cerebral palsy if they happen right near the beginning of life, and exactly how early on in life that occurs is a point of discussion. What's interesting is that the incidence of cerebral palsy did not change much over a long period. There were studies in the 1940s and studies in the 80s and 90s which showed the same incidence. We think the reason for that is that we got much better with our care of children that were born prematurely. So many years ago, a child born in 23 weeks would not survive. But in our time, children born at 23 weeks do survive, and they're at high risk of having cerebral palsy. So that's kept the incidence stable, even though we've improved some other factors. What's very exciting in our times is that there are early interventions that can be done, which is starting to influence the incidence and make the incidence less. This includes cooling premature babies, giving babies at risk of cerebral palsy magnesium or even caffeine. Many good studies are going on right now which are actually starting to make a difference. Diagnosis of cerebral palsy is primarily done through clinical observation. We see delayed motor milestones, the milestones we just talked about. A persistence of primitive reflexes, reflexes that are present in the first few months of life that should go away, be integrated into a mature nervous system as time goes on. But we don't see that if there's been damage to the nervous system, such as in cerebral palsy. Abnormal postural reactions. Postural reactions, for example, when a child is being put to a sitting position when they're about 5 or 6 months old, when they start to fall to the side, they should put one arm out as a lateral protective reflex. And if we don't see that, we are worried that there's some neurologic problem that may be causing that. And just any form of normal neurologic examination, abnormal reflexes, increased tone. Also, an early hand preference. If you see a child who's 3 or 4 or 5 months old is showing a hand preference, you have to be concerned that the other hand is not working well because of damage to the brain or possibly damage to the brachial plexus, and that has to be examined. The history, looking at the risk factors that we looked at, is very important, as is our imaging studies. However, despite the fact that cerebral palsy is a problem in the brain, about 13% in a study that was published several years ago have normal imaging. So many times we really don't have a clue, especially in children that are born full term and have normal imaging. We're not really sure why they're presenting with cerebral palsy, and genetic testing and other testing can often be helpful. Sometimes we never really figure out. Oh, how do I go back? Okay, there we go. As I mentioned, cerebral palsy is the most common cause of physical disability in childhood. The incidence numbers are between 2 and 2.5. There was a good study that came out recently that said 2.11 per 1,000 births. That makes it fairly common. Now, it's nowhere near as common as autism, which recently saw was 1 in 68 births, but it's much more common than, say, pediatric strokes, which may be 1 to 2 in 100,000 births. So this means that 1 out of every 350 to 500 children will be born with cerebral palsy. Cerebral palsy is classified in different ways. One of the most common ways to classify it is based on the type of motor problem the child has. The most common, as you see in the graph there, is spasticity. About 82% of children have spasticity, and we'll talk more about what that is in a moment. A smaller percentage have hyperkinetic. They have motor problems called athetosis, chorea. I invite you to look those up on YouTube to get some pictures of what those look like. But they're uncontrolled movements and where the child is not able to motor plan and not able to control their movements. Dystonia is somewhere between hyperkinesis and spasticity, a twisting movement that has high tone. Ataxia is motor planning problems with fairly normal tone. It can lead to an irregular gait, a widened gait, falls, and so forth. And many children have a mixture of what I've said above. Spasticity, as I mentioned, is the most common motor disorder in cerebral palsy. It's defined as increased resistance to passive stretch, which is velocity dependent. So in other words, when you try to put the limb through the range of motion, there will be a catch, there will be a stopping, and the faster you try to move it, the more resistance you get. Spasticity is high tone in muscles. The muscles become tight, and this leads to contractures, can lead to the hip being pulled out of place, as I mentioned in that growth slide before. It can also lead to decreased mobility, activities of daily living, ADL, problems with activities of daily living independence. The children become more dependent than you would expect for age, and increased care needs. I mentioned dystonia are twisting motions with fluctuating tone. Often children have some dystonia mixed in with spasticity. Now, cerebral palsy has a lot of comorbidities. We tend to think about it as a motor disorder affecting the muscles, spasticity, and so forth, but there's many other things that go with cerebral palsy. As I mentioned in the definition, there can be problems with seizures. Hydrocephalus, increased fluid in the brain, as we'll talk more about with spina bifida in a moment, can be something we see in cerebral palsy. Problems in vision and hearing are fairly common. Problems in swallowing and feeding, and as I noted, children who have problems with swallowing and feeding can have decreased nutrition, decreased growth, and have problems with health. Constipation is a very common problem in cerebral palsy that we are treating often in our clinic, and scoliosis has increased risk in cerebral palsy as well. There are also cognitive and psychosocial issues that we need to be concerned about. Although many individuals with cerebral palsy have normal cognition, I know many physicians and other professionals and college students with cerebral palsy, there is a high incidence of cognitive impairment. More than 50% of individuals diagnosed with cerebral palsy will have cognitive impairment. There are also behavioral issues and attention deficit issues and learning problems, educational problems. This is, after all, damage to the brain, and so that all of these problems can occur and need to be dealt with in the schools. As far as psychosocial problems, there is the child's adjustment to disability. As the child goes through childhood and interacts with children who don't have disabilities, they have to deal with all of the issues associated with that, as we'll probably talk more about throughout the LEND program. And then there's the family adjustment. Everybody has hopes and dreams for their baby when the baby is born. When a problem like cerebral palsy comes into play, the families are devastated, and there's a lot of work we need to do to help them to work with that diagnosis. All neurodevelopmental disabilities require a treatment team to really help that child to maximize their function and maximize their development and get the best quality of life. Not all of these players are on every team, but on many of them. There are a variety of physicians of many specialties: physical therapy, occupational therapy, speech and language pathology. The school is very important, the psychologist, the brace maker, the orthotist, nutrition. There's many here that I've left out, but there's a large team that's needed to really help a child with a neurodevelopmental disability such as cerebral palsy. Let's talk about a few of these more specifically. For example, the physical therapist. Their role is encouraging developmental gross motor skills. So when the child gets to the point in life where they should be sitting, if they're not able to do that, they may work with them on sitting devices, When it comes to standing, they may work with them on standing frames and standing devices, as well as working with their motor skills in an attempt to help them to do these things independently. The physical therapist focuses on ambulation, and if a child is not able to ambulate independently, they will work with them on assistive devices like walkers, crutches, and canes. Of course, physical therapists work on strength, range of motion, flexibility, and they'll work on wheelchair fitting for children that need that for their mobility. Another thing they work with is bracing and orthotics, and they work with our orthotists, our brace makers, for this. Here's a few examples. The ankle-foot orthosis helps to stabilize the ankle. Children with cerebral palsy often have weakness at the ankle, and their spasticity tends to pull their ankle into, as I mentioned, some of these dystonic positions that make it difficult for them to walk. The brace will stabilize the ankle, prevent the foot drop, and prevent the pronated position. It also helps to control the knee so that the knee doesn't bend too much during walking. If children have less weakness, less spasticity, they may just have some problems with how their foot and ankle work and need a lower brace like the ones I've demonstrated here. The occupational therapist works on activities of daily living. They also work with smaller children on what's called developmental stimulation, where they basically are just working on developmental skills. They work on feeding and swallowing, on equipment needs. Pictured here in your slide is a Rifton bath chair where children can sit safely and receive a bath. And they work on upper extremity range of motion, coordination, and strength. Just to highlight one of our occupational therapy-based programs, this is the CHAMP program, the Comprehensive Hand and Arm Movement Program. There's been a lot of research over the past several years that has demonstrated that repetitive activity and mass practice can be helpful in improving skills in all ages. And there's been a big focus on this in cerebral palsy, especially children who have impairment of one arm greater than the other, what we call hemiparesis. So this child has more impairment of their right arm than their left arm. So what we're doing here is casting the left arm and forcing the child to use the right arm so that the neural pathways that control their right arm will grow and flourish, and that child will gain skills in their right arm. This has been a very successful program, and there's been a lot of spin-offs and different versions on how to do this. Our speech-language pathology team works on communication skills. One of their specialties is augmentative and alternative communication. I've pictured several of the devices that they may use to help a child who's unable to verbalize to communicate. They also do a lot of feeding and swallowing and are involved in swallow studies. I've pictured here a child who's getting a swallow study to make sure that they don't inhale their food as they're eating. Let's talk for a few minutes about some of the medical interventions, some of the things that are more in the doctor's clinic. So I use medications for that tone. There's a number of medications. Medications are tricky. They all have side effects. A lot of them cause sedation, so we're concerned about the child's ability to learn. We have to ask ourselves, is a little better movement worth it at the risk of impairing their learning? Sometimes medications are very helpful. There's botulinum toxin and phenol, which are injected. So when I have a child who's got a very focal problem, let's say a child who has difficulty reaching forward, so I may inject botulinum toxin or phenol into their biceps muscle to loosen that muscle and allow them to reach forward. This is a very common intervention we do to help children with their movement. The orthopedic surgeons help us as well by changing biomechanics. If muscles get too short, as I've talked to you about as far as the growth of muscles, they can do procedures which actually cause the muscles to be longer. And if the bones come out of place or if the bones are turned a certain way because of the way the muscles pull, they do procedures which change that. There are some very interesting neurosurgical procedures which we do to help reduce tone and spasticity. This includes the selective dorsal rhizotomy, which is a spinal surgery that reduces tone. It's a surgery where we cut some of the nerves in the back to decrease sensory input into the spinal cord. That allows the child to have better motor control and better motor movement. We've been doing this since 1988 and been very successful with this. The baclofen pump, which you see pictured here, is a pump that delivers a very low dose of baclofen, which is an anti-spasticity medication directly into the spinal fluid. And this treatment has been very helpful in reducing tone and giving people more freedom of movement. So finishing up with cerebral palsy, I just want to talk about aging with cerebral palsy, and it's kind of a model of aging for many of our neurodevelopmental disabilities that have physical parameters to them. So as people age, we all get musculoskeletal problems, but if there's bone and muscle problems growing up, there'll be more musculoskeletal problems. There'll be chronic pain, fatigue, and there's poor fitness levels as well. And all of those things can contribute to a phenomenon we call early aging, which is decline in mobility and motor function at an age much earlier than you would expect. So individuals who've walked all their life, losing their walking skills in their 20s and their 30s, even folks who are mildly involved, losing that skill and needing a wheelchair more in their 50s. A phenomenon of cerebral palsy that we're working on in terms of, can we do more with fitness? Are there other things we can do to help people with this early aging phenomenon? Accessibility continues to be a problem, and especially as people get older and they lose some of their mobility skills, even though the American Disabilities Act has mandated that all facilities, public facilities, be accessible. People have different definitions of accessibility, and some facilities are old, and sometimes there's problems with accessibility that people have to deal with. And then medical care. As people with pediatric onset disabilities grow up, and this will really go across everything we talk about with LEND, they often have a difficulty finding physicians who will care for them because the pediatricians like seeing kids and the adult physicians don't like the pediatric onset type syndromes. So this is an issue that we're working on at a national level for cerebral palsy to try and increase the number of practitioners that are interested in adults with cerebral palsy. Spina bifida is a fetal malformation around the spinal cord. It happens in about 28 days of gestation, about 4 weeks. And what happens is there's improper closure of the spinal cord and the spine. There's a genetic tendency for this, and it's related to a folate deficiency. Women who are at higher risk for spina bifida in the family, are supposed to take folate for at least 3 months before they plan on getting pregnant, and then all through the pregnancy to help prevent spina bifida. What happens is that the spine actually doesn't close, and the spinal cord is exposed in the intrauterine environment. And so the spinal cord is bathed in uterine fluid and meconium, which is extremely damaging. What's absolutely fascinating is that one of the innovations we've had in spina bifida is intrauterine repair. So there is a surgical procedure now that's done where the woman who, at about 27, 28 weeks, the uterus is opened up, the baby is removed, the spine is closed, and then the baby is put back in and then delivered at full term. If this does not happen, the baby is closed when the baby is born, but closing the baby intrauterine has markedly decreased the motor deficits that we see in these children. The clinical findings of spina bifida are dependent on the spinal level. Children who have their spina bifida low down in the sacral area often have very little motor deficits, will often have some bladder and bowel problems, as we'll talk about. The higher up the spinal level, the more deficits we'll see. So here are the functional limitations of spina bifida, again, depending on spinal level. Children at the L4 level will have knee extension and will be able to walk with shorter orthotics. That's kind of what we see with our young skater there at the top picture. Children that are more T12 to L3, they have more involvement of muscles, can often walk with long braces, which are called knee ankle foot orthoses, KFOs, or RGOs, which are special braces, which reciprocating gait orthoses, which have some cords in the back, which actually help the legs move. The young lady standing in the picture there is wearing RGOs. And then children who are at a higher level are generally dependent on using wheelchairs for all of their mobility. As far as hand function, there's generally some impairment, but they're generally functional in hand function unless the spina bifida is very, very high into the cervical area. Their independence in function varies on their level, their cognitive function, their obesity, which is a tremendous problem in spina bifida, and family support. All those factors play a role in how functional and how independent they will be. There are a number of important comorbidities to understand in spina bifida. This includes hydrocephalus, which is increased fluid in the brain. You see I have it pictured there, and the intervention for this is a shunt placement. The Chiari malformation is when the brain is actually being pulled down into the foramen magnum, the opening of the skull. This happens because of a problem called tethered cord. As children grow, their spinal cord tends to move upward, but in spina bifida, that often is prevented because of the abnormality of the spinal cord. The spinal cord starts to stretch. That causes all kinds of problems, but Chiari is one of them. Scoliosis is another problem that can be related to growth and related to this tethering of the cord, but it's also just related to some weakness of the muscles. And the x-rays I showed there, the last x-ray shows a rod placement designed to put that spine back in order, which is a common procedure in spina bifida. There's also cognitive deficits because spina bifida is not just a spinal cord problem, it's really a whole nervous system problem. Neurogenic bowel and bladder are extremely important comorbidities that we see in the spina bifida population that affect life quite a bit. The bladder just does not function correctly because of the damage to the spinal cord as well as damage to some of the nerves that occur. Because of this, the children often have to pass a catheter into their bladder to empty their bladder. There can be a lot of problems with infections. The picture I have there is the Mitrofanoff procedure, which is the process of passing a catheter through the abdomen using actually the appendix, attaching it between the bladder and the abdomen so that the children can cath through their abdomen, which is very helpful for children who are unable to cath themselves through their urethra because they're not able to get at their urethra because of their motor difficulties. We do a similar problem for children who have neurogenic bowel. There's all kinds of medications we do to help the neurogenic bowel, but sometimes we do what's actually called a MACE procedure, and you see the young man there who has a catheter going into an opening in his abdomen, and he's putting an enema through that catheter, which helps him to empty his bowel. Children with spina bifida often have areas that are insensate, and they're at risk of decubiti for that. Let's talk a little bit about neuromuscular diseases. There are many, many neuromuscular diseases, and I'm just giving a couple here as an example. One of the most common, the one that everybody is very familiar with, is Duchenne muscular dystrophy, which is progressive loss of muscle. It's onset about age 3. Initially, it's the proximal muscle, and I have the picture up there, the famous Gower's sign, which children get as they're losing their proximal muscles, then it goes to the shoulders. Eventually, all the muscles are involved. The cardiac muscle can be involved. There's a loss of ambulation, which is inevitable. Children, by the time they're anywhere from 12 to 13, 14 years old, lose the ability to ambulate, and scoliosis becomes common. There's a milder form called Becker's as well. Spinal muscular atrophy is progressive loss of motor nerves at the spinal level. There's different forms. The most severe is type 1, which has onset in the first year. There's really no motor development, and it's fatal. I should have said fatal without ventilation. The less severe types are type 2 through 4, onset childhood through young adult, and loss of ambulation is later based on onset. Many of these children do require home ventilation if we want them to live past a certain point. For Duchenne's muscular dystrophy, children really don't live past 18 or 19 years old without ventilation. For the SMA that I talked about, they will die by 2 years old if they're not ventilated. This requires extensive care, and we've been talking about this here in the care at home model, where we've been doing a lot of technology things to support the caregivers at home, simply using their cell phone to communicate with them, having them show us images back and forth, and being able to read the ventilators from long distance using telemedicine. Ventilation can extend life, and we have college graduates with Duchenne muscular dystrophy because of ventilation. What's interesting about these two syndromes, and I wanted to highlight them, is their etiologies and potential cures for these syndromes. Duchenne muscular dystrophy is caused by a protein called dystrophin, which is a protein malformation due to a gene deletion found on the X chromosome. Because it's on the X chromosome, it's predominantly in males, because females have a normal X chromosome that allows them to produce the protein, but males have just the one X chromosome, and it has the abnormal gene, and therefore they don't have the proper protein. Well, there are new drugs called exon-skipping drugs, and there's also this CRISPR gene editing technology, which is helping individuals with Duchenne muscular dystrophy to produce the proper protein, and potentially significantly limiting the effects of Duchenne muscular dystrophy. This is something that is growing. There's many other options that I haven't even talked about here as far as Duchenne muscular dystrophy, and there's a lot of work going on with this that I think we'll see some changes in the future.
Hi, Ed.
SMA.
Ed, you have a question?
Yes.
I have a question for
Yes.
you.
Yes.
Coming from Shanae, could you define, and please forgive me if I do not pronounce this correctly, could you define decubiti and insensate areas?
Sure. Insensate areas are areas that have no sensation. The patient has no ability to detect when they're being touched in that area. Decubiti are bed sores, I think, is the common term that people use. If you sit on your skin if you sit someplace long enough and don't move around, you're going to lose blood flow to that area. All of us, when we sit and watch a long movie, or perhaps some of you right now as I'm saying this, will adjust yourself in your chair because of the lack of blood flow to the skin on your bottoms. But if you don't have any feeling there, you won't adjust yourself. And if you haven't learned to adjust yourself, just knowing to do it without even feeling it, you will tend to get lack of blood flow to an area on your bottom, and the skin will start to break down. Okay, Shanae, I hope that helps. Going back to SMA, is there's a dysfunction of the SMN1 gene and a loss of the SMN, which means saved motor neurons protein on chromosome 5. It's also recessive, which means that both parents have to have it for this to happen. And there's a new drug called nusinersen, I think I'm pronouncing that correctly, which is injected intrathecally, which means by spinal tap. It stimulates the SMN2 gene to produce SMN to replace the SM1 gene. It has had tremendously positive effects, keeping children alive, keeping them functional. It's been an amazing in its studies. There's a very interesting thing that happened with the nusinersen, and then the FDA was moving at its normal pace, and there was a tremendous outpouring of advocacy to get this drug approved so it could be used, and the FDA fast-tracked it so it could be approved. Perhaps both of these syndromes will be gone someday. Let me just finish up with traumatic injury, just to point out some of the differences. So traumatic brain injury can be like CP, especially if it's in an early age, but there's a lot of variance in the residua of traumatic brain injury. It can be mild residual with just behavior and learning problems, or severe, looking like a severe case of cerebral palsy with motor and cognitive deficits. What's interesting about traumatic brain injury, different from cerebral palsy, is that there are learned skills from the normal time of development before the child has the injury. And those previously learned skills, they're less in children than in adolescents and less in adolescents than in adults. People go back to those learned skills, and that's what helps them the most, and they have difficulty learning new skills. So sometimes people think that if you get a brain injury at the earliest part of life, that's the best thing because brains are, quote, plastic. What we've really found is that the more you've actually learned in life, the better you can do with a brain injury. Traumatic brain injury patients have a lot of difficulty with getting on with their life, working with the previous relationships they've had, and they get therapy similar to CP. Spinal cord injury as something that happens later in life, the functional outcome, just like spina bifida, is dependent on the level. The pediatric onset causes some of the same problems like scoliosis. They have neurogenic bowel and bladder and skin issues. But what's different is it's just a spinal cord problem. So they'll have normal cognition and normal hand function, for example, if they're paraplegic, which makes them very different from spina bifida. So, in conclusion, neurodevelopmental disabilities can affect growth, which leads to physical and functional differences. Neurodevelopmental disabilities affect development, which leads to different levels of functional attainment, depending on physical and cognitive severity. And therapies and medical treatment play an important role in maximizing function and improving quality of life, along with other interventions.